This is a welcome back to Dr. Anderson, who actually met with our Learning Environment Committee at a bi-monthly meeting probably about a year or so ago. Let me tell you a bit about him. He's an assistant professor, Division of Child and Adolescent Psychiatry at UC San Francisco. His background is that he obtained his Bachelor of Science in chemistry and then his Master's of Science in biological engineering at MIT. And I'm just going to add that he picked up 4 awards and honors while he was there. Then he went to Chicago to do his MD at Northwestern Feinberg School of Medicine and picked up another award. Then he started his adult psychiatry residency at Mass General, McLean Hospital in Boston, Massachusetts for 3 years. And then he finished this off with doing his 2-year fellowship in child and adolescent psychiatry at UC San Francisco, where he picked up another 3 awards. So he's a prolific author. He's, in addition to publishing in Scientific American, the New England Journal of Medicine, and being a featured interviewee on NPR and other sites, he writes for many other periodicals, and especially on social media, X, which is formerly Twitter. And I wanted to just sort of give you a bit of flavor of of some of his titles. I just picked out a few of them, and here they go. Here I go. I'm a psychiatrist, and here's what I want people to know about my suicidal ideation. Honestly, it's okay to ask me about it. That's one. I'm a Black gay physician. I'm here today because my friends saw me, all of me. Here's an op-ed. We're kind to our patients. Why not to each other? Understanding minority stress. We're going to hear a lot about that today. That saved my life. Life after depression, a physician in remission. I'll just give you a couple more of these. And also, the masks we wear to survive, the weaponization of professionalism. Medical schools are failing minority students. And in Kevin MD, a physician's experience of bigotry in medicine. And on a more personal note, I wanted to just tell you something else about Dr. Anderson. My next book, which is coming out next year, is on physicians living with psychiatric illness and how their stories make us better human beings and better clinicians. And when I approached Dr. Anderson, he was very gracious in having me interview him. And after about an hour or so of speaking, we had to wind up. And I wrote this at the end of this section, which is in the book. Our interview ended on a very upbeat note. Dr. Anderson stated, and I quote him, "I have to come from a place of love. There is so much negativity in the world, so much hate," end of quote. And I came away, I'm speaking about myself now, with a warm feeling of being in the presence of a true wounded healer, a wise junior colleague who's passionate about changing medical culture, especially what we teach and the way we behave in our medical schools and residency training programs. His perspective column, quote, taking back our voices, #humanity is our lane, end of quote, in the New England Journal of Medicine is a must read. So please join me in welcoming Dr. Chase Anderson, whose talk today is Minority Stress and the Medical Professional, How Minority Stress Affects Mental Health. Welcome, Chase.
Thank you so much for having me. And I love that you did such a deep dive on old articles. It's very appreciated. And just, I hope you know how much I love working with you and getting to be in touch with you. Um, it's really nice to meet all of you. I'm really honored to be here. And so we're going to start the presentation. So I don't have any disclosures. I am not getting money on the side for anything. So we're going to move on from there. So the talk today will be minority stress in the medical professional, how minority stress affects mental health. This was a previously 5-minute presentation that a colleague and I put together, Mark Fusenyan, at MGH when I was much younger, and it was a QI project. So this is the only time I will say that QI projects can launch your career. In terms of an overview, part 1 will be a personal vignette, so to show what minority stress can do to people. Part two, what is minority stress? So some definitions. Part three will be minority stress in America and in healthcare. So in case people are like, racism doesn't exist, you can be like, I have statistics from research about this. Part four will be anecdotes of minority stress. These are things that Mark and I heard on the units and from other patients and staff. Part five will be how do we help and how do we grow? Part six is how can minoritized people protect themselves? A lot of talks are geared towards white people. And so wanted to add a little bit more for minoritized people who come to these talks in terms of letting them know these are ways that you can look out for yourself. And these are other ways that bystanders and other people who are allies can help too. Part eight will be a personal vignette revisited. So that's actually part seven. And then part eight will be a Q&A. In terms of learning objectives, at the end of this presentation, learners can or will integrate into their practice the ability to specify at least 3 ways in which minority stress affects mental health, assess how minority stress can affect minoritized trainees and faculty in the medical system, and identify at least 3 ways in which we can make academic environments safer for minoritized trainees. Before we start this personal vignette, I am very open about my own mental health and living with a history of 2 suicide attempts. I know that that is sometimes activating for some people to hear about these topics. And so I want everybody to make sure that they're doing what they need to feel comfortable as we go through this talk, even if that means stepping away for a little bit. I will stay after for a little bit as well in order to process with anybody who needs to. My life changed when I came out at age 12. Until then, I'd lived this idyllic little life, one where I was educationally and economically privileged in ways I didn't even know at the time. I hadn't heard the N-word yet. I knew the world was hard for gay people from newspapers, but I didn't fully grasp how things were about to change. Through the next years into high school, I was called the N-word, homophobic slurs, and I went through bullying because of facets of my identity. Even though I was one of the top students, even though from the outside many people thought I lived this perfect little life, even though I made it look good, people didn't know that my smile hid so much. I didn't know what to call it at the time, but I began to develop depression and anxiety. I feared going to school even though I loved learning. In high school, because of discrimination I faced, I had 1 suicide attempt. No one knew I wasn't hospitalized. My mom, dad, and sister helped me survive those years in various ways, even as I hid my mental illness. Then I entered college at MIT and my life changed for the better. Not at first, though. Within the first few weeks, I was rejected from a fraternity because I was open about being gay, had to meet with MIT faculty about it, and subsequently failed all my first exams because I developed panic attacks for the first time. I was no longer a stellar student, and I was sure I was going to fail out. This led to my second suicide attempt. Again, no one knew. I was ashamed to openly say what was going on inside. I thought I also was going to end up dead. Yet, something different happened. The friends I'd made at MIT validated my experiences of discrimination, shared their experiences with discrimination and mental illness, and how they dreamed of changing the world. We bonded more tightly together, and we learned how to support each other. We saw each other as more than the characteristics often used to define us and shattered those stereotypes. We became a family where we spoke of topics of diversity regularly and shared our lives with each other. Because of them, I made it my purpose to help others not experience the same issues I had. I got to see also what it meant to truly live. It wasn't perfect, and there were still instances of discrimination, but it became more rare as time continued, and there was nearly always someone besides myself who spoke up against such instances. Those friends saved my life. They helped me soar for the first time as I embraced my identity, and we celebrated each other's identities. Because of our friendship, because of my family, without meds or therapy, I entered what I later called the golden years right before grad school at MIT. A 2-year period where I didn't have a single depressive symptom or any suicidality. I thought my depression was gone forever. I left MIT with the certainty that America was ready for a shy yet confident, Black, gay, introverted guy nicknamed Dream in a unicorn phoenix by his friends. Medical school, however, was about to disillusion me and bring back the one thing I thought was cured forever. I became class president in the first few weeks of medical school, and things became a slow descent into hell. I also show these pictures to show that you can be smiling and still have things going on. I was told by a classmate that I won class president because I'm Black and gay. I heard about how I talked about being minoritized too much. I started to get shut out and shunned, even from events I helped plan with classmates. 6 months in, my depression, anxiety, and suicidality had returned. Every day became about social navigation, balancing class president, finding allies, including our vice dean, certain deans and attendings as well, educating people constantly about the discrimination they were enacting, taking on certain deans who had enacted discriminatory behaviors, making changes with others, handling schoolwork, and planning my escape from medical school. All the while, my identity fractured. I began to fail exams. I cried alone in my room at night and woke screaming from nightmares. I couldn't even tell my friends from Boston or family in Seattle what was happening because of the shame I felt and had been made to feel. Because of all of that, I started medications and therapy for the first time. Yet, even with meds, therapy, an abundance of friends in medical school, and alliances built, that didn't stop the flood of constant discrimination that continued to break me. I failed 4 shelf exams in a row. I'd never been felt and been made to feel more alone. This led to one night in third year where I had plans and intent to suicide. After that night, there were several breakthroughs, including being more open with my friends in Boston and family in Seattle about how bad medical school was, and I honored my surgery shelf and taught myself further tools to more fully face down discrimination. However, I felt like a shell of a person who once dreamed of more. Although my psychiatrist, therapist, and I agreed I entered clinical remission in my 4th year, my symptoms flared whenever I experienced discrimination. I couldn't figure out why my depression didn't fit the classic criteria we use in psychiatry, but clinical remission was enough to hold me steady. I then matched back in Boston at a university where the program director said during interviews that she hadn't heard about issues about being Black, but if there were issues, I'd be supported. I raced back to my friends in Boston, hoping to feel truly safe again. In residency, I saw the descent into chaos coming a bit better this time. For my psychiatry rotations for the first 3 months, I was told I was above where I needed to be. I thought I had found safety. Even when an attending who was also minoritized warned me that appearing to be confident and competent as a Black gay male would lead to discrimination and backlash, I thought that couldn't be true. Then, on my internal medicine rotation, I had an attending who kept pimping me in front of colleagues in a way that caused my panic attacks to flare. When I told her this, her pimping worsened. I heard how she'd done the same to other trainees. In the hospital, I was being called the name of the only other Black psychiatry resident who looked nothing like me, asked if I was there as transport. My knowledge and the knowledge of other minoritized people was constantly questioned, and I was disparaged by some patients and staff and saw the same happen to colleagues. 1 week later found me standing at the sink in the hospital bathroom, crying before rounds, suicidal, having to force myself to go to work and not run away. On her evaluation, the attending said I was unprofessional, was worried about my being a danger to patients, and that my knowledge was far below my peers. Although other evaluations said I was above where I needed to be and praised my professionalism, my program directors labeled me as unprofessional, rated my knowledge and professionalism below my peers, and I was ignored and told I was the problem when I told one of them what was happening at the hospitals. I had to do a pseudo remediation with the internal medicine chief resident mornings after working overnight where senior residents said I excelled. Faculty had supposedly secret meetings about my not wearing a tie. I'd rarely felt more embarrassed or that I was the problem. My suicidality worsened in frequency and intensity. Because of so many lived experiences, however, this time I knew what to do to survive. With my residency class, we strategized how to handle program leadership and make changes. Then we went to war with our program when we deserved peace and a safe training environment. I set aside the guy who wanted to simply date another guy and have a calm life in order to mentor others, push where I could with faculty, support my colleagues as well. We led with vulnerability and used as powers we spoke up constantly when we all wanted to sit in quiet peace and dream upon the stars. This time around, I was open with my friends from college and family in real time about what was happening, even as I had less time with them because I didn't have the energy. My colleagues set aside many of their dreams as we spoke up constantly and consistently. I restarted my antidepressant, which I'd been able to come off of after leaving medical school. I started therapy again. I wasn't just scared I was going to lose my life, I was terrified as I watched my spirit fade. 1 year later, soon after one morning where my suicidal thoughts became more intense with intent, then I went on to have an attending tell me my work was excellent that day, aka saying that we were very bad at telling if somebody's suicidal and that you can perform and nobody can know. The same program director who hadn't listened when I told her about how bad things were was crying as she apologized to me for how she hadn't listened, how she had put me in a horrible position, for how she and the program had hurt myself and others. Then she and I got to work. Every week, we'd meet to discuss aspects of her identity, the programs, certain instances of discrimination I'd experienced or classmates experienced. This was all on top of working to be the model minoritized physician. That didn't stop the depression. It didn't stop the daily discrimination I saw or experienced, but it did help to have a leader who validated myself and others who worked at better things. At the same time, I was planning my escape from the program. I also began to speak out about experiences under a pseudonym on Twitter, or X, because I wanted people to not feel so alone. When the co-program director, who was now an ally, announced that she was going to another program, that solidified my decision to fast track. During interviews, I had better questions this time around, because for minoritized people, it's not simply about, oh, this is a great program. It is about, where will I be safe? Where will I experience the least discrimination? Faculty at UCSF were the most honest. I matched at UCSF. Then George Floyd was murdered, and people who had enacted discriminatory behaviors were rushing to apologize, invaded my space when I wanted to be left alone. Our program even said how they had hurt people, but never specifically apologized to anyone, and discrimination continued. We forgave because we saw it as people having blind spots and enacting learned behaviors from society, but that didn't stop the knowledge that the rush to assuage their guilt and these delayed apologies didn't heal our shattered hearts or give me back my lost time, dreams, peace, or sense of self. So I geared up to leave with plans to leave academia. Fellowship was more of the same. Began saying goodbye to my oldest friends and newer friends and mentors, wishing that the program had been safe enough for me to stay in Boston with my friends who had promised to be together forever with. So what does that all have to do with minority stress? So the typical definition is the process through which stigma directed towards sexual minorities influences health outcomes. This term came into being before 2003, but Dr. Meyer is the one who is known for pushing this forward into the public consciousness. He was looking at LGBTQ people and noted that a lot of people were thinking that maybe gay people and queer people are just predisposed to be more depressed. What he saw was that they were going through these things called minority stressors, which would then lead to worsened mental health outcomes. A lot of other minoritized groups then saw this definition and were like, oh, this applies to us as well. So there's the minority stress theory from that. Individuals from oppressed social groups experience excess stress and negative life events because of their non-dominant status or statuses, which can lead to or exacerbate mental health problems. These effects are unique, socioculturally based, and long-lasting, which means they're additive. The way I describe it to the kids I work with and other people is, think about getting a paper cut. That's like my being called the N-word at the beginning of the day. I can probably patch that up and actually be okay by the end of the day. However, imagine getting called the N-word and other homophobic slurs or racial slurs throughout the whole day. You're getting 1,000 paper cuts per day and you don't know how to put yourself back together and you're bleeding all over the place. The other way I describe it is, a lot of the kids know that I like to watch Sailor Moon, the original Japanese version. She has this thing called the silver crystal, which encapsulates all of her shine and who she is. Imagine getting a crack in that shine. You get one crack and it starts to leak light all over the place, but you're like, I can patch this up. Now imagine getting 1,000 cracks in your shine. Eventually what will happen is that your sense of self shatters and you don't know how to put yourself back together. Along with this comes institutional discrimination. So these are disparities that systematically favor certain groups. This includes housing. So in the 30s, there was this thing called redlining back in Chicago. And so that was, houses were appraised at different rates for African Americans, and they were only allowed to live in certain places. This actually still plays out today, even in places like SF. This also applies to housing or schooling, employment, health, and justice. So this is the minority stress model. And so I wanted to bring forth a diagram. I'm going to make it a little bit bigger so I can make sure everybody can see it. We're going to go through this model for transgender people. What I want you to realize is, on the left side, they have these things called distal stressors for the minority stress model. I want you to think of these as external things. So these are things that happen in America to people. These external stressors, so things that happen to people, can include things such as gender-related discrimination, so difficulty getting appropriate healthcare because of being transgender, gender-related rejection, so being rejected by family or by peers because of being transgender specifically, gender-related victimization, so experiencing verbal or physical harassment because of gender identity, and then non-affirmation of gender identity as well, so not respecting somebody's pronouns. Respecting people's pronouns has been shown by surveys and studies to actually reduce suicide attempts for people. All of that, those external stressors, can lead to outcomes such as worsened mental and physical health, including higher depressive symptoms or higher rates of depressive symptoms, substance use, anxiety, and suicidality. What this sadly can also lead to is, if somebody's transgender, they start out by thinking, I know that America is the problem. However, if they get enough of these external stressors, they become internal. So these are labeled as proximal stressors. However, I want you to think about these as internal. And so these can include things such as internalized transphobia, so feeling embarrassed about one's gender identity or feeling embarrassed about other transgender people and saying, I'm the right type of transgender person. There's also going to be negative expectations. So, actually thinking that even if you meet somebody who is kind and supportive of you being transgender, if you've had enough people who are not supportive, you have a negative expectation that the next person you meet will not be supportive. This can also lead to non-disclosure. For people who are transgender, this is also known as going stealth. So that means that they are not acting in the ways that they want to because they're trying to blend in with the predominant society. So all of that can also lead to worsened mental health and physical health outcomes. However, thankfully, there are things that can block this. This is why I show those pictures of my friends at MIT at the beginning. They're known as resilience factors, but with the kids, I call it strengths-based factors because I don't want kids to feel like they have to be resilient enough. So the first that can help with minority stress and mitigate it or block it completely is pride. So feeling special and unique and having a transgender identity. There's also community connectedness. So that can be having a transgender community, that can be having an LGBTQ plus community, or it can be just a community of people who are supportive of you and are allies. As you saw in those pictures from MIT, a lot of my friends did not look anything like me. However, they were accepting and they were supportive of me as myself. And so that was helpful. I'm also going to close my windows really quickly. So, how does minority stress play out in America and in healthcare? In terms of some racial statistics, a study by Randy T. Lee looked at major lifetime discrimination and noted that it was 48.9% for African Americans for major lifetime discrimination. It was 30.9% for white people. The reason it's so high for white people is that women were included in that category as well. In terms of day-to-day discrimination, 44.4% of white people said that they had never experienced day-to-day discrimination. Only 8.8% of African Americans were able to say the same. This also plays out in terms of pay discrepancies. So they looked at the people who came at the same entry level and did the same amount of work and were passed over for promotions or be given less pay. And so they know this happened for 57% of African Americans, 32% of Hispanic Americans, 31% of Native Americans, 25% of Asian Americans, and versus 13% of white people. This slide is a little bit busy, or there's a lot going on here, but I want to draw your eye to the yes regularly column. This is yes regularly experiencing discrimination. For white people is noted to be 3.82%. For every racially minoritized category, it's higher. For Black people, it's 11.23%. For Asian Americans, it's 10.85%, and so on and so forth. And I don't want you to memorize any of the definitions that we're going through right now. This is just to build awareness. And I'll talk about a little bit later that even just building awareness of what can happen to people leads to decreased bullying and things like that. So don't worry about memorizing anything. I can also send these slides later if you would like. In terms of youth identifying as LGBTQ+, so they look at different high schools across the country in a biannual study. All sexually minoritized adolescents report higher rates of violence victimization. This includes feeling unsafe, forced to have sexual intercourse, being threatened with a weapon, being bullied at school or online. In terms of an example, for gay males versus heterosexual males, they noted that bullying was 27.7% versus 14.6%. That's almost double. Lesbians also reported higher use of cigarettes and marijuana use, and the prevalence of cocaine, heroin, methamphetamines, ecstasy, and inhalants were higher in sexual minority groups. The thinking back in the day in the training was, oh, maybe LGBTQ+ people are more predisposed to using substances just because of genetics. Genetics have been shown to only account for 50% of what might be going on. The other part is that people are experiencing minority stressors or discrimination. And because they don't have the coping skills necessary or the supports necessary, they end up using substances. So thinking about why somebody is using substances is incredibly important. This also sadly plays out in the prevalence of suicide attempts. And I want you to note that the numbers on the right for heterosexual people will be a little bit different. It's because they looked at 5 different high schools. For lesbians and gay people, it was noted to be 24.3% versus heterosexual people was 13.1%. For bisexual people, it's 28.3% versus 23.2%. For people who said they were unsure about their sexuality, the statistics reverse, and it's 12.4% versus 14.9%. The reason that the statistics reverse is that people who said they were unsure didn't display stereotypical gay traits or may not have come out in any way, so they were actually protected inside of the environment that they were in. In terms of drawbacks of this study, they saw that there were high dropout rates, and they also think there's an underestimation. So a lot of queer people actually form their identities and sexual orientation earlier than their straight counterparts. This predisposes them actually to being more open to discrimination because of that. So a lot of people might not have even made it to high school because either they dropped out, were forced out, left high school, or they suicided before then. And since the 2016 election, sadly, things have gotten worse. So the FBI keeps track of the hate crimes that are going across the country. They look at things like misogyny, as well as xenophobia, things of that nature, as well as homophobia, transphobia, all of those things. They've been noting that every year we've actually seen an increase in hate crimes. So who we elect as our leaders is extremely important as well. So a lot of previous studies had demonstrated poor mental health, but were done in predominantly white LGBTQ plus samples. So research has also demonstrated that external racial stressors among Asian American sexually minoritized individuals result in greater psychological distress. A study done at the University of Tennessee looked at Asian American LGBTQ plus persons and noted they experienced rejection, prejudice, discrimination from the overall LGBTQ plus community. So just because somebody is LGBTQ plus and part of the queer community, it does not mean that they are not experiencing racism or transphobia from their white counterparts or from other parts of the community as well. So thinking about how different parts of our identity can clash or help us and be protective. They also saw increased internalized heterosexism or internalized homophobia because of violating traditional Asian values such as harmony and complementarity. And among 314 LGBTQ plus people of color studied, 58 of whom were Asian American, they saw higher rates of depression, perceived stress, and need for acceptance. There's also this thing that they saw called ethnosexual mythology. So this is fetishizing by a different name. So the example that I give when I give this talk other places is when I was in Chicago and in Boston, and I was on dating apps, I would have people who open their messages with like, "I love your black skin," or "I love how black people smell." And I was like, this is not the opener that you think it is. So that is something that minoritized people who are racially minoritized go through on a daily basis, even on things such as social media. This also leads to the need to talk about intersectionality. So, this is the interconnected nature of social categorizations such as race, class, and gender, which create overlapping and interdependent systems of discrimination or disadvantage or advantages. The example that I give for this one is I sit before you and I'm queer and African American or Black. And when I used to walk by police people, I would get really scared about it because of the shooting of unarmed Black people in America. And so, what I would do is I would actually inflect my voice even higher. I used to talk at a much higher pitch, and then now I talk at my lower pitch because I'm more comfortable and confident. But for 22 years, I actually pitched up in a way that I had forgotten about until like during therapy. He was like, "Where do you talk in your head?" And I was like, "Up here." And he's like, "No, it's down here." And I was like, so I cried during therapy because I was like, oh, I've been doing this for so long to try to adapt to society. So, how we use our intersectional natures can actually be protective for people. Along with this comes the intersectionality paradox. So, the thinking was that African American people, if they were at higher socioeconomic standing, they might be more protected from depression and from racism. Sadly, that doesn't play out, and they've done studies around this. They looked at African American women with higher education levels and compared them to white women, and they noted that African American women still had higher rates of depression. So racism is the issue. It just shows up in a different manner when somebody moves into an ivory tower, let's say. Along with this comes the something known as the multiple jeopardy perspective. It's also known as the multiple disadvantages approach. It's also known as the multiple hierarchy stratification. So I don't like this version as much, but I just want everybody to be aware that this is sometimes how people have studied these things. So this is assigning high and low status traits for different parts of identity. So an Asian American bisexual and a female in America would be assigned 3 hits for low status traits, whereas a white heterosexual male would be assumed to be the jackpot in America with 3 high status traits. However, there's a need to look at identity and experience. Just because somebody is a white heterosexual male does not mean that they haven't experienced discrimination other ways, such as socioeconomically, or gone through like bullying or things like that. Just means that certain parts of their identity have not caused them to be more predisposed to discrimination. So, how does minority stress play out regarding patients? So, a definition that many of us know about is microaggressions. So, broadly defined as behaviors that ambiguously disempower racial minorities. However, that's actually an umbrella term, and there are three other subterms underneath this. The first is microassaults, so explicit acts of racism or saying someone is of lesser worth. The next is micro insults, saying somebody didn't earn their position. The last is micro invalidation, saying we are all the same. We are not all the same. We are all different. And so it's recognizing our biases as we go and how to work against them. Along with this comes healthcare microaggression. So these originate from this term called aversive racism. So the thinking is that we aren't prejudiced, we don't have racist tendencies because we are healers. This also plays out in terms of this term that I think is the coolest term ever, but it's kind of a horrible thing. It's called institutional betrayal. So this is normalization of bad behavior. The example is that if a medical student comes to experiences discrimination from an attending and they go to their dean about it, and how that dean responds will actually portend how the person's mental health will go. If the dean responds appropriately and says, I'm sorry that that happened to you, and we will remove this person from teaching, or we will have them go through remediation, or they will never teach again, that med student's mental health will be better. However, if the dean says you are the problem and doesn't do anything about what happened, that med student is more likely to go on to have depression and anxiety and suicidal ideation. In 2017, Fitzgerald looked at how microaggressions can play out regarding patients, and they looked at vignettes specifically to examine the influence of patient characteristics on attitudes, diagnoses, and treatment decisions. Nearly all, so 35 out of the 42 articles, found evidence of implicit bias. This was bias around race, age, socioeconomic standing, mental illness, weight, having AIDS, patients who've experienced brain injuries, people who use intravenous substances, disability, social circumstance, and gender. They actually saw the same levels of implicit bias as the wider population. So if you took America and shrunk it down to the hospital size, you'd see the same rates of discrimination playing out. And when physicians were less certain of coronary artery disease diagnoses for middle-aged women, they were more likely to give those women mental health diagnoses compared to men. And intersectionality can actually play a large role in protection, like I talked about before. So how does this play out regarding residents? So we're pivoting a little bit to medical training and specifically. Lisi in 2016 looked at bullying, so repeated acts or practices directed at one or more workers, unwanted by the victim, done deliberately or unconsciously, but clearly cause offense, humiliation, distress, and may interfere with job performance and or cause unpleasant working environments. Examples of this are unjustified criticism, humiliation in front of colleagues, intimidatory use of discipline or competence procedures, undermining of personal integrity, and shifting goalposts. Shifting goalposts is this thing where if a med student comes to an attending on the first day and says, how will I achieve honors? Obviously, after they do introductions and things like that, then how that attending's responds, they would say, oh, you need to do X, Y, and Z. Then med student does X, Y, and Z. Attending then says, oh, you also need to do X, Y, Z, A, B, and C flawlessly. Med student does X, Y, Z, A, B, and C flawlessly. Then the attending says you also need to do D, E, and F on top of X, Y, Z, A, B, and C. They're moving the goal line so that med student will never actually achieve honors. 69.8% of residents in the US have experienced workplace abuse, and the most common form of abuse was verbal in nature. In terms of types of resident mistreatment and themes they saw a lot of hierarchy. So actually all of you can call me Chase. It flattens the hierarchy a little bit by using first names. And I tell my patients as well as the people that I work with to call me Chase as well. So trying to flatten that hierarchy as much as we can. They also saw a lot of silence, incognizance, fear. So 79% said they were afraid to report something when it happened to them or saw it happen to others. They also saw acceptance and denial and this thing called a legacy of abuse. If a med student is abused by an attending, they are more likely to go on and be somebody who is a supervisor who abuses other trainees. So how do we stop that legacy from happening? And if somebody goes through abuse, how do we help them heal? They also saw a sequela of resident mistreatment that plays out on the individual and systemic level. There's a cost to the system with higher rates of medical errors, harm to patients, and disillusion of care. 67% of who witnessed disruptive behavior felt it contributed to adverse events. There's also a cost to the individual with higher burnout rates, thoughts of desertion, depression, stress. They actually saw a lot of symptoms of PTSD playing out, such as nightmares, avoidance of places, things like that. Also higher rates of substance use and suicidal ideation. 20% said they would not pursue medicine again, and several would advise others not to pursue. So unsurprisingly, it's worse for minoritized trainees. So some of you may know about Justin Bullock. He is a wonderful colleague who has done huge amounts for pushing forward mental health inside of like being a physician, as well as he's written some of the most beautiful articles I've ever read. So I would highly recommend reading things by him. He also does a lot of work around medical education and putting names to the things that minoritized trainees go through during medical training. In 2020, he looked at minoritized fourth year medical students who experience this thing called stereotype threat. So I want you to think about as minority stress as something that starts externally and becomes internal. Stereotype threat does become like it's something that's external at the beginning, but I want you to think about it as an internal thing that becomes external. So stereotype threat is the worry that you will fit into stereotypes that other people have about you. So you start changing your behaviors and you have extra cognitive loads because you're trying to navigate everybody around you so you don't fit stereotypes. He also looked at supervisor biases and possible poor prior academic training. They saw that stereotype threat can be triggered by standing out or even being seen as standing out. So when I first got to the Zoom meeting, I was like, how many other African American people are here and how safe am I to talk about these things? So just that's how that can play out in some ways of being watchful of your environment. They also saw reliving of past experiences. So even if a rotation is great, if you've had a rotation where discrimination happened, you might be more predisposed to worry about that happening again, which changes your behavior. They also saw that even witnessing microaggressions causes a by proxy trauma for people where they can have worsened depression and anxiety. They also noted that non-white students receive less favorable med student performance evaluations and lower clerkship grades, even with working at the same rate or even more. So let's go through these anecdotes. So blank, this was a nurse voicing concern that a Black patient was dangerous because they were listening to rap music loudly while pacing the unit. This is from a friend who's an African American and queer social worker. He still remembers this event that happened on another team with a different attending and resident. An elderly Hispanic man was admitted for dementia, psychosis, and paranoia. The treatment team was rounding with the patient in the ICU. The patient became very agitated and angry because in his psychosis, he believed I had assaulted him at the facility where he lives. The Spanish interpreter reported that the patient was making racial statements and wanted me to leave the room. Not knowing how to correctly respond, the resident gave me a look that seemed to suggest that for the sake of the interview, I should leave. Feeling shocked by the resident's response and lack of response from the attending, felt I had to do what was being asked. Needless to say, I felt unsupported, stigmatized, and invalidated. I believe the resident and/or attending should have told the patient that I was part of the team and would need to stay. So the training back in the day, at least for me, I think this is changing now, was, oh, a patient is going through something or they're having a mental illness. That actually like means that it's okay for them to say these kind of things to people, or they're just not in their right mind as of right now. My colleague, who was African American, then looked up in the DSM and was like, racism and discrimination are not part of the diagnostic criteria that we use. So why are we allowing this and saying that it's okay when it's not? So what I want everybody to think about here is that this patient was in a safe unit. And so why didn't they protect their team member and say, we're going to step out for right now until you are able to interact with our colleagues in the way that is respectful? So how do we protect our colleagues as we go through medicine, and how do we not excuse poor behaviors? Because if somebody is having those behaviors on a unit, what are they doing in society in general? So Mark and I and other people, when we put this together, noted differences in attending evaluations when colleagues say that minoritized colleagues work twice as hard and work twice as good. People who are minoritized being interrupted by attendings when others who are not minoritized were not interrupted. This also applies to women as well. There's also this thing called the minority tax. So when somebody who is diverse comes into a university, they are often tasked with diversity efforts, and they are not given pay for doing that. They are not given extra time. However, they are told that they need to explain what diversity is, what racism is, how people should do better at universities. And what happens, sadly, is that those people, even if they make changes, eventually burn out and they leave that university. So how do we help with that leaky pipeline that we created? There's also tokenization. So if you notice on a lot of diversity websites, they will have the same picture of the same African American person, and it's just repeated 20 times. So how are we actually reducing somebody to their skin color and saying we are diverse when those people are actually not given the power to change things at their universities? We also had an attending say he had worked well with other African Americans before and they'd worked so well together. When we checked with other African Americans, this was not true. Wait staff who were minoritized being told by a white patient that they could finish the food left on a patient's tray. There was also constant misgendering of transgender patients and saying when rooming them, well, they're not actually female. We need to think about the safety of patients who have trauma from men. Staff sometimes saying that clearly that person has a personality disorder and noting it occurs mainly with LGBTQ plus patients. So even how we diagnose people, if you go by the strict criteria that's used in psychiatry, we misdiagnose people a lot, especially if they're minoritized because of our own biases. This happens with schizophrenia and African American people, and they're placed on multiple antipsychotics when what they're experiencing is minority stress or discrimination, leading them to have justifiable paranoia and things of that nature. Hearing that a patient is difficult or aggressive, and sure enough, they're a minoritized person, looking at notes and seeing how race is brought into the one-liners for specific patients. So a lot of notes will say like 58-year-old African American woman. You're already probably thinking sarcoidosis or diabetes or something of that nature. However, a lot of notes won't say like 28-year-old white person. So how are we predisposing people to think about patients in a certain way before we actually even enter the room? And why are we not doing race for everybody if we're going to be doing it for minoritized people? Staff and patients noting how there are no pictures of minoritized physicians on the walls or anything other than the nuclear family. So, how do we actually have people be represented in the hospital is important to think about too. So, how do we help and how do we grow? The first thing is we can ask. However, Mark and I, when we first did this, we were like, oh, you just ask. And then later on, when I started doing this presentation other places and expanded it, I was like, I do not want people asking me all the time about my experiences. Sometimes I just want to have a nice day where nobody bothers me. So I added a caveat to this. And the way I do it with the kids that I work with who are wonderful is I first ask them about their identity. And once they tell me, like, oh, I'm Asian American and bisexual, then I will later on say, because you said you were Asian American and bisexual, you may have experienced certain things inside of America that are not your fault because we know America is messy. The kids usually laugh when I say that because they know exactly where I'm going with things. And then I will say, you do not have to tell me right now, and I want to be thoughtful about this. However, have you ever experienced specific things around your identity that have caused you to have worsened depression and anxiety or suicidality? That, and you do not have to tell me now, but it can be a yes or no. And kids will, I mean, I work in a clinic where basically they're all minoritized and they will say yes. However, some kids are not ready to talk about that yet. And so that gives them an out. I have a kid who he's a young adult now and is 22. We met 4 years ago. And when I first asked this question, he was like, I'm not ready to talk about it. 2 years later, he's like, I remember when you asked me that question and told me I didn't have to answer right then. Now I'm ready to talk about it. So, how we talk to people about this can actually stick with them and help them feel safe. We also need to educate ourselves and protect minoritized people. There's a danger of being false allies. Posting a black square to Twitter, while symbolic, is not actually changing policy. So just things to think about of like, how do we actually in real time protect minoritized people? We need to come at this from humility, from seeking to understand and truly converse. I make mistakes still all the time. I'm still learning. This presentation just got updated in certain ways. And so just thinking about we all are going to make mistakes as we do this. Nobody has taught us how to do all of this and how to talk about this. So being gentle with ourselves as we do this and apologizing when we make those mistakes and doing better. So how do we heal? Lisi in 2016 also looked at how to heal from bullying. And like Lisi's article is one of the like coolest articles. Like I nerd out a little bit because it's just like so well written. So they looked at how education and awareness actually in and of itself, not even doing any actions, led to decreased bullying. So all of you coming to this talk and learning a few new things will lead to decreased bullying because you're more aware. They saw that team-based care at all levels led to reduction in the hierarchy. Good leadership, no surprises, led to prevention and protection and defined a better culture. And interphysician support led to better mentoring and fostering of community. They also saw that confidential mental health services were necessary for people. So why in hospital settings and in training do we not have an opt-out system for psychiatric care? When med students and trainees come into universities, then they start going through things and they have to scramble to find a psychiatrist or therapist. That can take up to 6 months to a year. I've had patients who they were like, I've been on this wait list for like UCSF for a year. That is wild. So how do we help trainees by setting them up with a psychiatrist early when they first get there, and they don't need to use them if they don't need to, or they can just touch base. And also, like everybody should go to therapy because like we all have work to do on ourselves. They also saw the need to develop a curriculum that tackles the hidden curriculum. So half of medical training is learning like thousands upon thousands of facts. The other half is social navigation. So why are we not teaching about that other half as well? They also saw the need for feedback standardization and safe mechanisms for reporting. And in the worst case scenario, they talked about this thing called exit strategies. So this will sound similar because I built this for myself of like how to get out of a university when it's unsafe. However, why are we not helping trainees when a university is not prepared to actually support them? How do we get them to a university that might be more beneficial for them without any blowback for that person? We also need to recognize, name, and understand these attitudes and actions, identify our own implicit biases. They also have talked about diversity training, not only about diversity now, but also how psychiatry specifically, as well as the medical system, has harmed patients. So how do we actually like create curriculums that talk about the history of medicine and what we've done to patients so we don't make those same mistakes? We also need continued research that address patients' social risk factors and needs and diversifying the healthcare workforce. This also has a caveat. When we first did this presentation, we were like, yeah, sure, just bring in more minoritized people. Then we were like, oh, we're burning out and we want to leave. So maybe that's not the best idea. So what you actually need to do is bring in people who have positions of power where they can shepherd like minoritized trainees through training and have the power to change things. Because otherwise, what happens is minoritized trainees will come in, they see the problems, and then they want to help fix them because they're healers and they're just driven people. That leads to them burning out and they leave universities. If you look at a lot of medical training areas, they will say, like, we have so many diverse people. Look at how many people stay from med school to residency and look at how many people stay from residency to faculty positions. You will see it drop off usually significantly because people got tired and they left. So how can minoritized people protect themselves? We're almost done with everything. So thank the goddess Beyonce. There are actually techniques and strategies to protect oneself. So what they've noted across 134 studies, and this is still playing out today that they've seen this, having a space to actually express what happened to you and then problem solving strategies are the two ways to actually help people. So when you say something and somebody says like, I validate what you went through and I'm sorry, that gives that person like it helps ungaslight them basically from what they've been going through. And then problem solving strategies help them move forward. So it helps them be in the present and think about the past and then moving forward. So that's how it pulls all of that together. They also saw the neat importance of community and like pride is what they saw. So basically the things I talked about before for minority stress theory in general. And they saw the other things that helped were social support, spirituality and religion, humor. So humor is one of the best techniques that we have in psychiatry. It's one of the mature defense mechanisms. Role shifting, so actually masking yourself and using different parts of your identity can be helpful too. Armoring, reinterpretation, even withdrawing for self-protection, as long as you're not avoiding completely, can actually be protective for people. So sometimes I'm going to tell you all, in med school, when I saw certain people walking down the hallway that I'd gone up against, I would actually go hide in the bathroom sometimes because I was just like, I need to get away from these people for right now. That actually did help me. So sometimes people are already doing things that are positive techniques for them. They just need to figure out how to like also have a way to problem solve too. No, Chase, we need some specifics. So the APA, American Psychological Association, wrote this other article that's very cool about disarming racial microaggressions. So they have different techniques. So the first is making the invisible visible. So this would be me getting on an elevator and seeing somebody who's not minoritized pull their purse closer to them. And I would say, is there something about me that's making you uncomfortable? All of these techniques I'm going to bring up need nuance and they need practice because during those moments you have fight or flight or freeze basically. And so you have to practice them so you're ready to use them when like things happen to you. So the kids and I actually practice them during sessions and stuff. It's very cute as we like run little scenarios. There's also disarming the microaggression. So just saying, I don't agree with what you said, you don't engage after that because otherwise the person can double down. You set a clear limit and then you move on. There's also educating the offender. So this is one of those techniques where you need to know your audience. Will that person be able to receive you educating them? There's also seeking external intervention. So that was my going to the vice dean and saying, there is a problem at this medical school right now. And her listening was powerful and changed my life. She actually, we just texted because I was like, I gave grand rounds somewhere and I'm going to do it again. And I've been doing it for years. She knows this, but I was like, I mentioned you. Is that okay? And like, I kind of checked before and she was like, you can use my name if you want to. Like, so she is still a friend and she has read all my articles and always likes my things on Twitter. And I was just like, you have been that straight white woman ally that like got me through. And she knows how now, once I came out about my suicidality, she was like, oh, now I really get what you meant when you said I really helped you. So It was very cute. We have a long-lasting friendship. There's also setting clear limits. It's a little bit like disarming the microaggression. There's redirecting and reframing. There's also a longer article I can send everybody about disarming racial microaggressions, and these are intervention strategies. This is the flow chart that they created. It's the coolest thing I've ever seen. Again, I like nerd out about this sometimes, but basically, you don't need to memorize it, but they made a flow chart of how to tackle microaggressions and at the different levels. So, like they did macroaggressions, so societal issues, microaggressions towards like that are institutional and that are person specific as well. So I can send this to everybody later. So, how did that vignette that we began with end? I flew to San Francisco and cried in my apartment that night from missing my friends, relief that I escaped an unsafe environment, and over the loss of my once dream to stay in Boston forever with my friends. Over the next weeks, I took time to myself to reflect, to look to the future. A few weeks later, I revealed my true identity on Twitter because I felt safe, and then I began my fellowship. Within a few weeks of my arrival, my depression and suicidality vanished, and I entered the third remission period in my life. I am currently, Michael knows this, I am coming out of my 7th episode of depression. So I've had 4 episodes since then. Each has been triggered by minority stress things. However, each time each episode gets shorter, and I recognize that my suicidality represents something that needs healing inside of myself, or it represents disharmony in my environment, and then I can tackle those issues. So when I work with the kids, I actually will say, like, what does your suicidality represent as a problem that you feel like you cannot solve? That demystifies it a little bit for them. And then we work on the problem, and then we like build it, break it down into steps. I'm also sharing with you that I'm in my 7th episode because I want anybody who's on here and going through that to also know like there's somebody out here with you who is right here beside you as we go and has not stopped me from living my life as well. So just wanted to share that. I found a program where my program director said to me, "You never have to take on issues with racism if you don't want to. It is not your job to handle these things." And back that up with words and actions. Oh, and a quick thing, all my work knows that I'm going through a depressive episode. I've been open about it online and how I'm taking steps to heal as I go through and how I'm moving faster. And so my job trusts me because they know I have my plans in place that if I cannot run my permutations for patients, they know that I will let them know to step away from work. I've never had to do that, but people come up with their own systems. So not being scared about mental health and people caring for patients without actually knowing how that person knows how to care for patients with mental health issues. It is not your job to handle these things and back that up with words and actions. I got to work with co-fellows who spoke up around instances of discrimination before I had to say a word. I had the opportunity to work with mentors who looked like me, who focused on what really matters, helping kids, their families, and our world. After 7 years, I finally found overall safety and broad support in academia. I began to fully live again. I got to again become more fully that unicorn phoenix nicknamed Dream by his friends years ago. I'm very different, but similar in the important ways. I've had time to work on articles around minority stress, do lectures at other universities like this one, engage around topics of diversity by choice and not for survival, skip down the street listening to K-pop, go gay clubbing, sit and simply breathe, build a family here with old friends and new, be fully present with when I see old friends in Boston and my family in Seattle. I have been able to see just how far someone can fly when not constantly barraged by discrimination. I found an environment like the one I had in college and graduate school where I feel safe. The scars are still healing, and it might be a lifelong process, and it will take time, but those cracks are healing, and I couldn't feel more fortunate. Because of all of that, I graduated 2 years ago from fellowship at UCSF and decided to stay as faculty. I'm an assistant professor. Some of you know what I've been shortening that assistant professor to. It's like kind of inappropriate, so I'm not going to say it during this presentation. Part of my work with others is being medical director for a program that we built and are expanding specifically for minoritized youth that involves trauma-focused behavioral therapy, cognitive behavioral therapy, healing from discriminatory trauma, peer groups for parents and kids around discrimination and mental health. We're starting the groups in November, so I'm very excited, and collaborations with other clinics. In honor of the friends, family, mentors, and people I love who once upon a time saved my life, the clinic is named after our group nickname that started in college and graduate school, which is the Muses. When I told my friends that I was naming the clinic after them and our group nickname, a lot of them cried. It was like the best thing ever because I was like, you saved my life, so let's go save some kids. Thus, our team has called our program that opened July 2023 the Muses Program for Minoritized Youth. And I'm excited to see where all these new chapters I get to write with all of you take us. So this is with special thanks to Mark for being my partner when we first did this. And it was a like 5-10 minute presentation. and then Dr. Myers and everybody else as well. All right, that is everything. I know that when I give this talk, sometimes people need to like sit with this for a while because they're like, this has been my whole life. And sometimes they need to process. Sometimes other times people like don't feel comfortable asking questions in front of colleagues, so they might message later. So I am here for any emails that you want to send after as well. And I'm open to any question. As you saw, I put my mental health out there. So like I'm here for anything.
Chase, thank you so much. Really, really appreciated this really comprehensive scan of the world. I mean, it really has been wonderful. I'd like to welcome anybody, either if you want to put something in the chat or if you'd like to unmute yourself and ask a question or make a comment, please feel free to do so.
Nice to meet you. I'm the training director here at SUNY Downstate in psychiatry, so I wanted to let you know that we're in that tiny subgroup together with Dr. Myers and others on the call. I still remember when I was a chief resident and starting the interview season that my program director said, well, you've chosen to tell everybody that you're gay, so I'm going to schedule you to meet with any applicants who also identify as gay. And, you know, I had an internal awareness of just like feeling like that wasn't all of me, but I felt seen as if that was the only lens that he could apply. And so people on the call who know me know that this wouldn't be a surprise. I said to him, well, you're a very conservative Orthodox Jew. Are you going to meet with all the Jewish people that are going to interview? And I said, with respect, you haven't said anything about the fact that I have type 1 diabetes, which is actually much more, you know, prominent in my health, in training, and part of my discipline choice. And I had mixed feelings of feeling righteous and stupid, but also I felt sort of embarrassed that I sort of attacked him. I felt that I wished that I had, you know, more ability to be calmer. But I guess I'm saying this also because we're always in a hierarchy. Like I expected him to know better because he was the training director. And yet that's an unfortunate, naive assumption on my part. And so we've recently in my program here, I literally got another email from a resident. I've invited residents to join what we're going to call a diversity work group. And I've said, I will not chair this work group because I don't know as much as I wish I did. And you are all so much closer to this and more versed in talking about it. So, and I said, I'm tired of teaching you guys everything. I want to learn from you as we go through it. I'm very aware of being a white cis male, you know, at a county hospital where I used to wear a lot of ties, and I've tried, it's been very hard for me, but I've actually not worn ties as much anymore because the residents have given me feedback on what that looks like. And I'm just trying it out. You know, I feel like we're in a moment where we can trust each other, that we're trying stuff out and laugh about it and, you know, all that stuff. So anyway, I don't really have a question. I just wanted to say thank you for being so, just who you are. I think that's the best way to say it. So thank you.
Thank you too. And also thank you for being so open in front of everybody too. It's really, I love when people share their stories and feel comfortable too. Thank you.
I second what you just said, Chase. Thank you, Scott.
Thank you.
Thank you so much.
If I may ask just a quick question, this is more pointed. Firstly, this is my second time hearing you, and it's such an experience to go through your narrative and to, you know, really glean so many important data points from the research that you share. You mentioned something about pronouns and suicidality. And, you know, inherent, and I will share, I'm a parent of a gender diverse child. And, you know, for that and many other reasons, I'm aware that, that this is important. It's something I've tried to inculcate as a culture at Downstate, or at least contribute to, as I think it is, we are moving in that direction. but it's been more intuitive. I wasn't aware that there was data to support that this has such a profound effect, like you mentioned about really preventing suicide. Can you tell me a bit more about where we can learn more about
Yeah.
this?
One of the places that I would suggest first is the Trevor Project. They actually are a wonderful website that talk through like they've expanded their website, and what I've loved is seeing them change because at the beginning when I first like looked at their stuff, it was mainly white centered, and I was like, okay, like I've heard this before. They have actually upgraded how they've done things. So it talks about like not only gender diverse youth, but gender diverse youth of color. They've done a lot of surveys around this too. And so they have surveys that actually look at basically how discrimination impacts people and what has been beneficial in terms of like helping people too. So they are like one of the best sites that I would start with for like people who are youth. And I've actually then adapted some of that to adults and things like that, and it works out well. The other place is sometimes the Human Rights Campaign has some good things that I have found. Healthline, there is this person, his name is Brian. Let me look it up really quickly. He's done really awesome articles. Brian, I have to go to Instagram because that's where we follow each other. He's done articles in Healthline that have been really pivotal and impactful in terms of how he brings together research.
Excellent.
And,
I'm going to find it if you don't find it right away. Don't worry. Great looking.
Brian Mastroianni. So MASTROIANNI.
Excellent. Terrific. I'll definitely be checking out those two resources. Thank you so much.
And there's this one as well that I just found too. Also, thank you for finding the Trevor Project part.
Thank you, Chase. You put that in the chat. Yes. And also Taryn has put in the Trevor Project in the chat as well. Dr. Cheng, please unmute yourself and
Hi, thank you again so much for this talk. I think this is my second time hearing you as well, and I always learn a lot from everything you bring. One thing you mentioned in this talk is about exit strategies, and I just wondered if you had, again, like more resources or where we can learn more about that. I think that comes up. I do a lot more work with residents compared to med students, but you know, we just came out of National Physician Suicide Awareness Month, and I know in the New York area there was at least one more resident who died by suicide. And I think when we did our institutional panel last month, you know, that question kind of came up about what do we do when we have no options left. And I think for some residents, they don't understand or know the concept of an exit strategy, or even that such a thing could be possible, and then suicide ends up being the option that's felt is left. And I just wonder how you brought that to your institution, or how do we raise awareness to that as being an option, both for the institution and for our physicians and our trainees, because I think some of the concerns that are brought up are about, even if you try to sort of exit, then what are the repercussions? And I just wonder if there's ways that we can bring that up safely.
Yeah, I'm gonna send Michael the article around the Lisi article that talks about it a little bit. It's been a while since I read it, so like I should go read it again. But exit strategies is not something I've looked at as extensively, so I'm gonna be like open with all of you that like that is an area I haven't delved as much into because now I'm safe. So I'm like, I don't need to worry about like exiting UCSF as of right now. And I kind of had to build my own exit strategy, but you're bringing up a couple points. The first is that when I was suicidal, like what happens is I get trapped in my own head, not as much anymore. Like each episode I get better and better. I'm like, you're not trapped, you're okay. But I remember like in my head, Mike knows about this, but like one of the articles I wrote was about like masks I wear to survive and things like that. And one part of myself was like calculating everything. And what would happen was that I had the idea and got trapped into this distortion of like, if I leave med school, my friends are going to think I'm a failure and then I'm going to kill myself. or I'm going to leave med school. I will like be the problem that like actually shuts the door for like all Black and queer people coming after me, or like they will never have another Black queer like class president. I have to get through this, or I'm going to kill myself. The problem that was like suicidality was at the end of every single step. So even exiting seemed dangerous to me, because I was like, if that domino falls, will it cascade and hit everything? Now, as an attending, like I had something happen at my job when I first started, and it was like I was working at one site and I was doing split sites. And then something happened and I was like, I'm not doing this. And then I like reached out to my supervisor, my career mentor, who's my previous program director. And I was like, yeah, the site's not great. And she was like, yeah, we'll get you out. And then I was done. Like, I wasn't like, oh, I'm going to suicide because of this. So I think talking to students about how are they linking everything together? What are they worried about with an exit strategy is something that I like really think about, because then it can help you figure out, are they linking everything together instead of like, oh, you go to another university. Yes, it's going to be hard. Yes, you're going to like need to find new friends. Yes, you're going to have to worry and have negative expectations like I talked about, and figure out how to be queer or racially minoritized at that university. However, that means you might be caught in a distortion of like, how can we help you realize that maybe it might be a better place for you or a better fit? And there is something, I hesitate to say this, but I think we can go there as a group. There were times like looking back, like if you told me what I was going to go through in med school and residency now, like I love being a child psychiatrist, but if you told me that mess, like back when I was at MIT, I would have been like, you are wild to think that I'm ever going to sign up for that. So this also brings up informed consent for applicants about like, this is actually what's happening at this university, so they can make an informed decision, because otherwise we are actually enabling like worsen things. However, also just thinking about like, how do we help people take a step back and realize like, maybe medicine is not like, it's okay. It is okay to not be in medicine sometimes. That is symbolic, not of you, that is symbolic of a system that is not protecting minoritized trainees enough. So is there something else that we can help you with until medicine is ready, or a place that we can help you find? So if somebody had talked to me in that way, I might have quit actually, but I was so stuck in my head that I was like, I have to do this. And so if you want me to, I can look up other exit strategy things. But those are like, I can send the Lisi article, and then just thinking about like, how is that person thinking an exit is? Are they linking a bunch of things that actually you can help them unlink and be like, this is what going to another university could help with. I hope that helps a little bit.
Thank you, Chase.
Yeah.
Thank you very much. We've got time for one more question, and then we'll have to move on. Dr. Roman.
Hi, Dr. Anderson. I just wanted to first express gratitude.
Thank you.
Sorry, wasn't really expecting that.
Don't apologize. Emotions are beautiful.
Okay, pull myself together. The questions that I have. So I'm not a clinician. I'm a PhD scientist, and I work a lot with first-year medical students primarily, and it's fantastic work. And we're, I guess, trying to prepare them aspirationally, to sort of set them up best to navigate, the futures that you describe. But one thing that's come up a lot in working with students at that, when they're first coming into medical school, is thinking about, what it is to be a medical professional, and how not to lose one's identity and individuality as part of that, because that's the superpower that everybody has, right? And so one thing that I feel like I try to communicate, and I'm not trained, I'm not a clinician, I'm not a psychiatrist, is how to first say that it's okay to be angry. It's a normal reaction to be outraged, to be so full of rage at injustice that you see or experience, and that it's not being a professional. Where a professional comes in is, how do you manage that? What is it teaching you? And I think that's where I see a lot of conflict. And I see that's where a source of a lot of depression is unresolved rage. And so I'm wondering if you could speak to that. And the other thing that was on my mind was when we think about minoritization, I think about it institutionally because, personally, I feel like Downstate is a minoritized institute. And a lot of what we're talking about here, we live it. We are the lived experience, right? Our students, our faculty are speaking from that truth of that reality. And so when we teach it, it's personal, it's real, and that's not common. So I guess those are two big things I just wanted to raise, but the most important was just gratitude to you and thank you for your life-saving work.
I also didn't think I was going to cry at this. So, but it is a beautiful moment that we get to share together. So, and you're sharing with all your colleagues so they know it's okay to be like emotional about this. We are here to be emotional. We are here to save humanity. So what we're doing is our humanity right now. And I think the first thing is it's part of the tricks and the tips that I work on with kids. The first thing is naming it. We hide a lot of things. Like even with coming out about my suicidality, I was terrified, but I was like, you are losing your truth. You are losing yourself. You are hiding your voice. Name how angry you are. Name how painful it is to exist in a world that you love so much and you are being treated horribly by certain people because of their certain behaviors. You need to name that because if you don't go there, you are ignoring parts of yourself. So when I work with med students who are angry or I work with the kids, I'll take it from the kid perspective. I am going to be very honest here in case I haven't been so far. But when I went through things in med school and in residency, I had homicidal ideation sometimes, and I had to hold that. It started when I was really young with like coming out. I used to plan to like hurt people, and I didn't because I was smart enough to be like, you're a Black person, you know how that's going to go. And I also then like internalized it though. I hated myself because I was like, why are these thoughts coming up? Like I used to think I was a demon in some ways. And I actually had like a little bit this is the first time I'm self-disclosing this besides like friends. I had a little bit of psychosis sometimes with my depression, where I actually, when I would look in the mirror, I didn't look at mirrors until my depression went away the first time, and I've never had this since, but I would get horns that would come out of my head, and my face would turn darker, and my eyes would turn black. So I actually thought I was a demon, and I had to work against that and be like, help people along the way and stuff. And so that's again why my friends were so pivotal. Was one of the first things I noted was I could look in mirrors again. And so them naming those things and naming their truths and me naming my truth helped. So when the kids come to me and they're like, I want to hurt people, I'm like, that is okay. You have not yet. Why do you want to hurt people? So asking like the pivotal why question, that's the most important question we can ask in psychiatry, and validating them and saying, yes, I am glad that you were expressing this truth that you were angry. How could you not be angry with how America treats you or how your institutions treat you or how your attending treated you? When you were coming here to help people heal, you were coming here to further our humanity. You were coming here to change the world, and you were taught that you could and that you should and that you were beautiful. And now people are damaging that image. So it is okay. And like being there for those emotions, what you did just now, you named all of it. So why are we not doing that consistently with people? You did that for your colleagues just now, who are now going to go know that it's okay for other people to express themselves and for them to express themselves a little bit more. We are doing it right now. So how do you bring that in every day, in every moment? That's your first question. And then I forgot your second one because I got
Thank you so much. It was about institutions being minoritized.
Yeah.
And again, thank you for that.
Welcome. I think there's naming it, and the other thing that I love, I'm like such a little nerd that when I got old, I was just a little science nerd from the beginning. I want to understand the issue so then I can put names to it and labels, and then I can move past those labels. So how do we build awareness of like, you just named it. So your institution is minoritized in certain ways. how is it minoritized? How does that show up? So then you can tackle those issues and find other people who are going through it too. So then you unite, and then you like, that's why I like my friend group. That's why I show that friend group, is to say like, and even people in med school, I show that unity, and I show that unity now to say like, all of us look so different, but we named something and we had a higher goal of like, how do we unite across all of that to like maybe make sure people don't go through this anymore. So that's how I would think about it, of like naming it, so then you know what to tackle, know what the problems are, and then also like not forget the emotions as you go, and say like, this is scary, this is hard, and we're together through this. I hope that helps too.
Thank you. Totally does. Thank
So-
you.
So Chase, on behalf of everyone here, I'm sure that everybody has the same sort of feeling. We're so grateful to you for spending time with us, starting off our very important conference in such a well, both sort of academic and warm, loving way, and really setting a tone as we all move forward. We really appreciate it, and thank you so much.
Yeah.
Okay.
Very nice to meet all of you.